All right, good afternoon and welcome. I'm going to hold for just a few minutes to allow people the chance to log on. In addition to being here on Zoom, if you're already logged into Zoom, you're seeing us now. If not, then we're also streaming live to our Facebook page at SCAD Alliance. And after this, we will post a recording of the presentation onto the Facebook page, as well as emailing it out to the listserv. We give just a few more minutes for people to get logged in. And then we'll get started. So welcome everyone to Ask the Experts, a conversation hosted by SCAD Alliance. If you are new to SCAD Alliance, we are a nonprofit organization founded by survivors in partnership with leading cardiologists and health advocates to advance the science of spontaneous coronary artery dissection, or SCAD. One of our main goals is to support patients and families, and as part of that, we've developed this monthly webinar series. So we hope to be able to offer support and education to survivors and caregivers by engaging in conversation with experts on SCAD-related topics each month. I'm Rebecca Freeman, and I will be moderating and leading the conversation today. I'm a board member of SCAD Alliance and two-time SCAD survivor. So today we're talking about genetics. Is SCAD inheritable? Are my relatives at risk? Are there genetic conditions we should be screened for? We've solicited questions over the past 2 weeks via Facebook and email, and we really appreciate everyone who has submitted such excellent questions for our panelists. We'll do our best to answer all these over the next hour. One thing I do want to preface our discussion with is that there is minimal hard and fast data on SCAD. As an organization, SCAD Alliance is developing a large multi-center iSCAD registry in hopes of eventually having a larger data set. But at this time, there's not a gold standard clinical trial to give concrete data on this. So please know that everything presented today is based on the extensive expertise of these clinicians, and they'll be able to give us a great overview and guidance, but all specifics for each of us as individuals really do need to be developed with each of our own providers. So I'm going to give a quick introduction to each of our panelists, and then we'll get started. First, we have Dr. Mark Lindsay. Dr. Lindsay is a member of the cardiology division at Massachusetts General Hospital in Boston. He's investigating the genetic etiology and pathophysiology of human vascular disease, focusing on gene discovery and the developmental underpinnings of vascular aneurysms and dissections. Dr. Lindsay serves on the SCAD Alliance Scientific Advisory Board, and MGH is an iSCAD registry site. So welcome to Dr. Lindsay. This is Dr. Amy Kontorovich. Dr. Kontorovich is Assistant Professor of Medicine at the Aiken School of Medicine at Mount Sinai in the Division of Cardiology. And she's the Medical Director of the Adult Cardiovascular Genetics at Mount Sinai Medical Center. Dr. Kontorovich's clinical practice is focused on the diagnosis and management of individuals with heritable cardiovascular conditions, including vascular connective tissue disorders, aortopathies, cardiomyopathies, channelopathies, and sudden cardiac death. Mount Sinai is also an iSCAD registry site. So welcome. And Dr. Stan Hinken is Assistant Professor of Medicine at the Geisel School of Medicine at Dartmouth Hitchcock Medical Center. His area of focus includes aneurysms, fibromuscular dysplasia, myocardial infarction with non-obstructive coronary arteries, peripheral artery disease, spontaneous coronary artery dissection, and venous thromboembolism. Dr. Hinken is PI of the iSCAD registry site at Dartmouth Hitchcock. So welcome to you as well. So we're going to start today with an overview from Dr. Lindsay. I'm going to start with who needs a genetics evaluation? What does that tell us?
All right. Grab this. Just going to share my screen. Switch to presenter. Can you guys see that okay? Okay. So I'm just going to dive in and talk exactly what Rebecca just introduced, just sort of what we know and just a little overview about genetic evaluation in this condition. You know, one of the common questions that people, of course, want to know the answer to is sort of, you know, why did this happen to me? We can't always provide that information, but genetics is one way to sort of understand a predisposition to SCAD. The second most common question that I get is, you know, what about my children? You know, what is me having a SCAD, imply for them and their health in the future? So that obviously leads to the question of, is there a hereditary component to SCAD? And the answer is, of course, complicated. The answer is yes, but not always. And so if we think about SCAD as a condition, there are other conditions associated with it. Some of them are like fibromuscular dysplasia, where a lot of individuals with SCAD are later found to have fibromuscular dysplasia. But that is less heritable, although it is mildly heritable. On the other hand, there's a smaller group of patients that have highly heritable genetically triggered arterial disease, and that can also exhibit SCAD. That's a smaller percentage, but much more highly heritable. So how do we approach trying to figure out the difference between these different groups? And it's generally done by an evaluation and by genetic testing. And so one thing that we often end up in clinic talking about is what diagnoses are associated with the genetic testing that we can perform. And Dr. Kantorovich is going to elaborate on these more, but there are known conditions associated with connective tissue disorders that have a predisposition towards coronary artery dissection. And those are things like Marfan syndrome or Loeys-Dietz syndrome, vascular Ehlers-Danlos syndrome, and then rare cases, non-syndromic arterial dissection disorders. The actual gene tests that people send can be performed at multiple laboratories. There's not necessarily a best laboratory to perform gene testing. They actually all have to conform to FDA standards. But what's more important than the genes, then who does the test is which genes are tested and what are the panel of genes that are involved in arterial dissections and aneurysms. And there are, a standardized group of those genes that we look for and try to make sure are on a gene panel test for coronary artery dissection. They have a high degree of overlap with the panels that test for genetically triggered aortic disease. Some people with SCAD will be later found to have aortic enlargement, but most will not. But regardless of whether or not a patient does or does not have other aneurysms, these genes may be responsible for a predisposition to SCAD. So it's important that we ask ourselves sort of why we do this, in addition to finding those rare cases of a genetically triggered disorder. One of the reasons then is that it allows us to prognosticate somewhat better, meaning we have a group of patients and we understand their history, and therefore we can probably understand their future better as a group than ones that we have less information about. We can also, in the rare cases where we find a gene change, we can identify other family members who are at risk. And that is one of the ways in which we can think about folks and their kids and siblings and parents and whether they have risk. And then finally, sometimes there are genetically based treatment algorithms, things that we do, either monitoring or medication, that are based on that diagnosis. And then finally, just want to wrap up with, who should have a genetics or a familial evaluation in coronary artery dissection. Who are the people that we worry about the most or suspect the most? A family history obviously is really important. So if someone has a coronary dissection and they have a family history of an aortic aneurysm or an arterial dissection in another place, or even a SCAD, those are the folks that we think it's really important have have a cardiovascular genetics evaluation. Also, some people will have external features of a connective tissue disorder. I showed you some pictures of folks with Marfan syndrome or Loeys-Dietz syndrome. Those conditions are associated with external features and make us more likely to suspect a genetic predisposition. And then obviously, sometimes when we perform cardiovascular imaging and arterial imaging, we find other evidence of dissections or aneurysms remote from the heart. So say in the arteries in the mesentery or the arteries in the head and neck. You know, when we see the evidence of either aneurysms or dissections in those remote locations, that also prompts us to be more concerned that there's a more generalized susceptibility, and that susceptibility may be genetic in nature. So that's just a quick overview, and then I'll pass it along.
Wonderful. Thank you so much. I know especially that last slide is a common question of who should go see genetics, or so that really narrows that down. At the beginning, you mentioned FMD or fibromuscular dysplasia, so I want to pass over to Dr. Hinken to talk some more specifics on that.
Can you guys see my screen okay and hear me okay? Excellent. Well, thanks. I'm really excited to talk to you about FMD and SCAD today. And many of you who either have had SCAD or have a family member with SCAD, I'm sure you've heard about FMD or fibromuscular dysplasia. And there is a well-known association between fibromuscular dysplasia and spontaneous coronary artery dissection. And a quick overview of FMD itself. FMD is a non-atherosclerotic, meaning it's not due to plaque buildup, non-inflammatory, meaning it's not due to an inflammatory condition, vascular disease. And FMD can really affect any artery, although it does have predilection to the artery of the kidney and the carotid artery in the neck. And on your top right, you can see FMD of the kidney artery, and it's the classic string of beads sign. On the bottom right is fibromuscular dysplasia of the carotid artery, and these are the most common sites that are found of FMD, but it can affect other sites, including arteries in the legs, in the arms, in the belly, sometimes even in the brain. And it can present with your classic symptoms of string of beads or the classic signs of string of beads, but it can really manifest as stenosis, meaning a blockage, aneurysm, meaning enlargement, tortuosity, meaning just irregular vessel, or a dissection. So in the past, we thought that if we saw a string of beads, that was your classic presentation, and that's really the way it presented. But with the more recent registries, including large FMD registries, both in the United States as well as in Europe, we really have learned a lot about FMD and the way that it presents. And the prevalence, or the number of people that are found to have fibromuscular dysplasia and SCAD, really depends on a different study. And it also depends on how you image the arteries and where you image. So some places, for example, only look at the arteries of the kidney or the arteries of the neck, and some use ultrasound, others use CAT scan. So different studies have used different techniques to look at the number of individuals who have SCAD and then found to have FMD. And so it really depends on which study you look at and what kind of method was looked at to look at fibromuscular dysplasia and SCAD. And the numbers can be as low as 10% of people with SCAD have FMD to as high as 80%. And really, we think that if you look at the best method to look for FMD, which tends to be either a CAT scan of the arteries or an MRI of the arteries, it tends to be really about 50% or so of people with SCAD have fibromuscular dysplasia. And we've known about FMD for many years. And genetics of FMD actually goes back to the 70s and 80s when fibromuscular dysplasia was studied in families, and they did show that there are multiple family members that were found to have fibromuscular dysplasia of their kidney arteries and their carotid arteries. So at first it really looked like FMD was passed from one family member to the other, but then when it was looked at further, they really saw that the penetration, meaning how well the gene passed on from one member to another, seemed really irregular. And when they took a look at more family members as the generation went on, it seemed like the genetics was a lot more complicated, and there is really no one gene that that is passed on for FMD from one generation to the other. There has been a lot of great genetic studies more recently, looking back in the past 5 years or so, looking at both fibromuscular dysplasia and spontaneous coronary artery dissection. There's been exciting research looking at one specific gene of FMD, which is interestingly also associated with migraines, cervical artery dissection, and this gene was then studied in patients with spontaneous coronary artery dissection. It's really interesting that this same gene that was found in FMD also seemed to be more found in patients with spontaneous coronary artery dissection, even if they were or were not found to have FMD. So this is really exciting research that's happened in the past year or so, that we have a lot of new ideas of looking into this gene more. What's interesting about this gene as well is that this specific gene seems to be protective of coronary artery disease. So when we see people go into the catheterization laboratory and diagnose spontaneous coronary artery dissection, even older folks, they don't seem to have as much coronary artery disease. And maybe now there is a more interesting explanation for it, that this gene that may be somewhat responsible for SCAD and FMD seems to be protective coronary artery disease. But in any case, this is only one gene, and although it's more commonly found in SCAD and FMD, like I mentioned with FMD, it's unlikely that there's only one specific gene that is responsible for SCAD, and it's likely multiple different genes which are being studied, and also the environment in which you are. And as we know, SCAD tends to present in specific environments. More exciting research coming up is actually looking at blood work and looking at blood tests that may be associated with fibromuscular dysplasia. But the takeaway point here is there is no genetic test or a blood test at this point that is specific to spontaneous coronary artery dissection FMD. A lot of exciting research, and we may be there in 5 to 10 years, but nothing at this point. So I think really helpful information when you're going to the doctor and talking about your spontaneous coronary artery dissection and or fibromuscular dysplasia, and all of us have the same theme. It's really important to get information from the family that may be helpful to get an idea about genetics and where things may fit in. So the things to ask about from your relatives include high blood pressure, especially young age, in your 30s, 20s, 40s, high blood pressure during pregnancy, whooshing sound in the ears, headaches, especially migraines, dissections, meaning tears in the artery, aneurysms, and that means both aneurysms and medium-sized artery as well as large-sized arteries such as aorta, bleeding, and stroke, because all of those things are associated with fibromuscular dysplasia and findings in different arteries where fibromuscular dysplasia may be found. And now with the new research of this specific gene and new genes, maybe that's a good explanation why individuals with fibromuscular dysplasia do tend to get more migraines or do tend to present more with dissections in their neck. So a lot of stuff in the pipeline, a lot of exciting research. We'll definitely know more in the next 2 to 5 years.
Wonderful, thank you. That is always exciting to hear about the future research and realize, we're right in the middle of this. I wanted to turn over to Dr. Katarovich to discuss some of the specific conditions that are related or potentially related to SCAD.
You're on mute.
Great, thank you for unmuting me. Thanks. Thank you. I'm going to echo a lot of what Dr. Lindsay, Dr. Henkin, and Rebecca have already said, and hope to embellish on it as well. I would start by saying that one of the points Rebecca made was so important, and I just want to emphasize it, that since the landscape of research and even the clinical recognition in SCAD is new relative to a lot of other cardiovascular diseases, the associations are still emerging. And the ones we know about are the ones we can talk about today. New ones may continue to emerge, and some of the questions you may have may be ones we aren't able to answer yet because the research has not caught up yet with this fascinating condition. So the three genetic syndromes that I want to kind of touch upon were mentioned by Dr. Lindsay, including Ehlers-Danlos, Loeys-Dietz, and Marfan syndrome. These are all categorized as connective tissue disorders. Ehlers-Danlos syndrome has 13 types that have been classified. They're considered genetic, all of them, although the genes have not been discovered for all of the types. The commonest type that you may hear about is the hypermobile form. It's really quite common, maybe underdiagnosed. And although there may be an association with SCAD, it hasn't been confirmed, and there isn't strong scientific evidence base for that association. But there is multiple reports of association between SCAD and the vascular form of Ehlers-Danlos syndrome, which is much more rare. Fortunately, the genetics of vascular Ehlers-Danlos syndrome, unlike hypermobile, are very well defined. There's one gene, and when there are changes that are significant in that gene, individuals are potentially at risk for vascular Ehlers-Danlos syndrome. So SCAD can associate with that condition, and that's one of the diagnoses that would be probably the highest priority to clarify for someone who's had SCAD, because that one does carry significant health risks. And it would be important to know if a person had that, because as others have mentioned, it would be useful for prognostication, potentially surveilling for certain associated features. I would say that on the scale of priority, that the next most important diagnosis to kind of rule in or rule out for a patient with SCAD would be Loeys-Dietz syndrome, which is also a connective tissue disorder that can cause aneurysms and dissections, including SCAD. And then Marfan syndrome, which many people know about because of historical figures and celebrities who have had it. We typically think of Marfan syndrome as causing large vessel aortopathy, aortic dissection, but there have been reports of SCAD in patients with Marfan syndrome. And so I think we're still learning about these associations. We don't yet know how many patients with any of these diagnoses develop SCAD. It's probably the minority. And we certainly don't know how many SCAD patients have one of these syndromes. But because they're associated with other features, having a genetic evaluation can be worthwhile. So what is a genetic evaluation? Usually patients will meet with a genetic specialist, either a medical geneticist or a cardiologist who specializes in genetics, or a genetic counselor sometimes. But a genetic evaluation is more than just a blood test. And I think that's important to know as well, because the blood test is only as useful as the clinician's suspicion for a specific disease. None of the blood testing that is done for genetics is perfect. Some of it comes close, but much of it is imperfect. And so understanding the limitations of genetic testing is part of what a good genetic evaluation will do. It will include counseling about what the test someone will have can and cannot do. The other piece of the evaluation usually involves detailed history gathering about the patient themselves and the patient's family history, as well as a detailed physical exam. And that would be to look for some of the clues or features that can be associated with these syndromes. So for example, patients who have something like Loeys-Dietz syndrome or Ehlers-Danlos syndrome may have flexible joints, double jointedness. We call that joint hypermobility. They may have complications of joint hypermobility, such as joint dislocations or subluxations, kind of partial dislocations, maybe a tendency towards tearing of the soft tissues. And folks who've had frequent joint injury who developed a SCAD may be a group that would be under higher suspicion for something like Loeys-Dietz or Ehlers-Danlos syndrome. Other features may be related to the eyes. A history of something like a retinal detachment or a lens dislocation could be a clue for an underlying genetic diagnosis. The skin can be a clue as well. So one of the important aspects to the physical exam is the doctor or the provider would look at the skin. What is the texture of the skin? Is it stretchy? Does it have certain characteristics of scarring? Sometimes excessive scarring, disproportionate to the type of injury that can cause scarring, can be a clue as well. And also GI symptoms. Certainly a history of a bowel rupture or an organ rupture can be an association with vascular Ehlers-Danlos syndrome. It's really important that all patients who have had a SCAD know their family history, and probably worthwhile to kind of document it. What I'm showing on this slide is an example of the type of documentation that would be done in a genetic evaluation, which is a detailed family history mapped out in this fashion called a pedigree. Usually we look at 3 generations at least, but sometimes you need to look at more. And the idea is to find patterns in the family history that might give more guidance as to what the underlying diagnosis could be. So it could be maybe someone else in the family has had a SCAD specifically, but maybe not. And it's important to also think about other questions to discuss with your family members. I'll just put a plug in that Thanksgiving Day is National Family History Day, so we're a little bit far out from that. It's never too early to talk to your family members, and maybe with quarantine and you're spending more time home with family, it's a good time to have these conversations, but certainly sitting around the Thanksgiving table is a great opportunity to get some good family history. So yes, talk to your relatives before your genetic evaluation, know your own personal history, your medical history, and bring records. If you've had eye exams, if you've had surgeries, if you've had biopsies, and certainly imaging, those are all things to kind of gather together before you meet with your genetic specialist. Just a brief checklist about questions to ask your relatives. So if there's a known genetic diagnosis in the family, that's certainly information to share with your doctor, with your team. A SCAD, an aneurysm or dissection, anyone who's had a sudden death. So that could be a younger person who died suddenly and unexpectedly. It could be under suspicious circumstances, like a single driver motor vehicle accident or accidental drowning. Those types of circumstances would be more suspicious for potentially a cardiovascular explanation. Hernias, eye problems, specifically the retinal detachment or lens dislocation, any organ prolapse. So we think about uterine prolapse sometimes happening as a complication from pregnancy. If there's a uterine or a rectal prolapse that's unrelated to a pregnancy, it's more suspicious. Organ rupture, pneumothorax, which is a type of lung rupture, or any birth defects, skeletal deformities like hip deformities, club feet, flat feet, all things to think about, maybe taking note of, and also asking specifically about. I think that's the last slide, but happy to take questions as well.
Wonderful. Thank you so much to all three of you. This definitely goes through a lot of the overview and a lot of the questions that we've already received. I want to start with a common concern as I go into some time for straight questions and answers. And I want to start with Dr. Lindsay. A lot of times we'll hear, I'm somebody who's had a SCAD heart attack, I have 2 daughters. Should they be concerned about the risk? I know you guys have explained that there's not specifically a gene that we can look for necessarily, but what should my kids tell their PCPs, and is there anything they can do to mitigate the risk?
Yeah, that's obviously a common and important concern. I'd say, first of all, it depends on a lot of different variables. I think that the most important part of answering that question would be to go have a cardiovascular genetics evaluation. That would be really helpful for if you've had a SCAD, for a physician or a medical geneticist who familiar with the conditions to look for all those features that were just described, and to look for FMD. Both of those things can help people understand what the risk will be for their kids. So what I tell folks, people with definitive FMD that's diagnosed by, somebody who's from like a vascular medicine doctor, like Dr. Henkin, who knows what FMD looks like, have a very low risk of passing that on to their children. The 95 or 97% or some odd of SCAD are non-familial, meaning that their kids are at a low risk. The most common patient with FMD is a woman who has no relatives with FMD. On the other hand, the conditions that we described that require genetic testing to identify, have a high risk of passing on, more closer to 50% in most cases. Those are rarer conditions, but they are definitely put your relatives at higher risk, and that risk can be, quantified with genetic testing. So it depends a lot, but I think if you're concerned, then the most straightforward thing to do is to have an evaluation and have yourself evaluated, not really your kids, at least as a first step. There's no imaging we can do for your children, for instance, to say that they, when they're young, to know what their future looks like.
Right, it makes sense. So starting with genetics for the individual who's had SCAD.
And not always just testing, the pedigree and the family history and the physical exam are important.
Absolutely.
As the testing, if not more sometimes.
Absolutely. With that, is there risk of becoming pregnant after having SCAD, or family members being pregnant after SCAD? Say if I have SCAD, is my sister at risk during pregnancy?
I'm gonna pass it on to one of you guys.
Dr. Henkin, how about you?
Yeah, sure. So the question is, if I had SCAD during pregnancy, is my sister at risk?
Is my sister at risk, or future pregnancies for myself?
Yeah, that's a really great question, and I think that's really important, because a lot of women who have SCAD events are younger women who either had a SCAD event during pregnancy or after pregnancy, and are thinking about more children. So this is interesting, because there is really not great research out there first about attempting another pregnancy after a SCAD event during your first pregnancy. And interestingly, there is a nice case series from Mayo Clinic in that women who are pregnant and present with SCAD events tend to be more sick for whatever reason. And it may be a reason because they're pregnant, it may be a more aggressive SCAD, but they tend to have more complications. So at least from the guidelines that we have from American Heart Association statement from 2017, it's really important to counsel patients who have had a SCAD event during their pregnancy that attempting another pregnancy is probably discouraged. But we don't know. We just don't have enough patients who have had pregnancies after their SCAD event. It's, some patients that have been studied, again, from the Mayo group, I think it's less than 10 patients. 1 out of 10 patients or so had another SCAD event during their pregnancy. So it's really important to talk to a specialist in SCAD to discuss the risks involved in a new pregnancy. And a lot of it also depends on how are you feeling before pregnancy? How is your heart functioning? Do you have, do you have complications from your first pregnancy in your first SCAD. And then if you do get pregnant, it's really important to follow with a specialist, both in SCAD, but also a pregnancy specialist, an OBGYN that is also familiar with spontaneous coronary artery dissection. And then planning for delivery will be really, really important as well. So that's a long question about pregnancy with SCAD. And again, no clear answer, but you have to be really careful. In terms of, again, you know, I've had a SCAD when I was pregnant. Is my sister at risk for a SCAD event? Very difficult question to answer because, like Dr. Lindsay said, it depends. If you had a SCAD event that may be connected to a genetic connective tissue disorder and genetic testing is warranted, it's really important for that family member to also see a geneticist, a cardiovascular specialist, a vascular medicine specialist who can do a physical exam, get a good history, and think, are you at risk for same genetic disorder, and to consider genetic testing at that time. And if you're found, then obviously you're at higher risk of possibly having a SCAD event because you do have that connective tissue disorder. If there is no evidence of connective tissue disorder, it's hard to know. Again, it's the risks and benefits, but there are no recommendations at this point to at least screen for fibromuscular dysplasia in family members. So that's important to know. That's why history is so important. That early onset high blood pressure, the whooshing sound, the migraines, that may give you some clues to look for fibromuscular dysplasia in family members, but asymptomatic
It's frozen for me.
Me too.
Okay. Let's see. Looks like Dr. Lindsay and Dr. Hinken are frozen for me. Are you frozen, Dr. Kontorovich?
I'm not frozen, but I see everybody frozen.
Yeah.
All right.
Yeah. Do we have a question for, because we can hear you fine. Oh, there we go.
There he goes.
Looks like Dr. Henkin's screen is still frozen, but Rebecca, can you still continue with the questions? Oops, I think we've lost Rebecca.
All right.
Yep.
I am
Are you
back
there?
on,
Okay.
but I don't see anybody else yet. Is
Okay,
everybody-
well, we're here, so if you want to continue,
All right.
continue on audio, and we'll.
Awesome. I want to make sure that Dr. Hinken was able to finish kind of that last statement. It sounds like in terms of not asymptomatic screening for FMD.
Can you guys hear me okay now? Excellent.
Yes.
Yeah, I
Yeah.
just wanted to make that important point because, again, you know, this comes up a lot. I have SCAD and found fibromuscular dysplasia. Should my family member, my daughter, my sister be screened for fibromuscular dysplasia? And screening for asymptomatic fibromuscular dysplasia is not recommended.
Okay.
But again, that's why it's really important to get those symptoms from other people, such as migraine, such as whooshing in the ears, high blood pressure at age 25, because that may push you one way to another. But if you're just trying to find FMD, it's not recommended just because you want to know if you have it.
Look, right, absolutely. And following up on that, you had mentioned, you know, there's some of the challenges in diagnosing FMD. And I'm sure we'll discuss this. We're going to have a future just like full webinar on FMD for anybody watching who has even more questions. But then, you know, it seems like having that diagnosis may push one way or the other in terms of other risks. If you have been diagnosed as not having it, yet you have all those family background or personal background, you know, is that a time that we should, what else should you do? Should you pursue looking for a diagnosis?
Yeah, it's a great question. So if you have been diagnosed with spontaneous coronary artery dissection, most experts recommend screening for fibromuscular dysplasia, looking at the arteries from your brain to your pelvis. And usually, at least in our institution, the way that we do that is with a CT scan, looking at the arteries of the head, the neck, the chest and abdomen and pelvis. And that's important actually not only to look for FMDs, but like Dr. Lindsay and Dr. Kontorovich said, looking for clues of other possible irritable connective tissue disorders, other dissections or aneurysms that may give you clues. And so at least one-time scan to look for FMD is important. If you're not found to have FMD, then it's not recommended to screen anymore, because we at least think that FMD is present at birth. We think, we don't know, or it develops when you're younger. You know, there's kids that have fibromuscular dysplasia. Again, in terms of family relatives, if they find out that they have some signs or symptoms that may be consistent with fibromuscular dysplasia, it's good to talk to your physician. And depending on what kind of symptoms somebody has, then you and your physician can discuss what testing is appropriate. Sometimes it's a CAT scan, sometimes it's an ultrasound is a good way to start as well. So it's a really important physician-patient relationship to choose the best test for you.
Excellent, thank you. Dr. Kontarovich, I want to ask you, I know you mentioned and discussed the genetic conditions that we know have, Ehlers-Danlos, Sleety, and Marfan. What about other things such as some autoimmune conditions? Do we know anything about any relationship between SCAD and lupus, or SCAD and sarcoidosis, or other autoimmune things?
So there are a couple of reports out in the literature, kind of on a case-by-case basis, that have noted SCAD in patients with those kinds of diagnoses, specifically lupus. And just because there's both diagnoses found in the same person doesn't necessarily mean that the autoimmune condition has led to the SCAD. I think further studies, bigger studies would be needed to confirm if that's a real association or not. So it's tempting to connect the dots and infer that the autoimmune disease does cause it. It's hard to kind of understand how that could happen kind of mechanistically. I'm not so sure. So I think it would not be clear to me right now that we have enough data to say that. If you have an autoimmune condition, I don't think screening for SCAD would be appropriate. If you've had a SCAD, I don't know that seeing a rheumatologist for an autoimmune workup is perhaps necessary. The one caveat I would say is that joint hypermobility can lead to musculoskeletal pain, joint pain, muscle pain, and that type of symptom falls under the purview often of a rheumatologist and can lead to a workup for an autoimmune condition. But if you've had a SCAD and you have hypermobility and you have joint pain, it's probably more likely that it all could fit with a connective tissue disorder that's genetic, even if it can't be concluded on a genetic test, rather than searching for some extra diagnosis that would fall into kind of an autoimmune inflammatory disorder.
Right, that makes sense. Another question we got that is just a non-cardiac condition being related or potentially related. If somebody has Graves' disease or some other thyroid conditions, could any issues of kind of the racing heart symptom, would that be in any way related to a SCAD?
I don't think
Nobody wants.
I mean, Graves is a form of autoimmune condition.
Yes.
I think what Dr. Kontarovich just said still applies to Graves. And I don't think there's any data that the thyroid disease plays a role either.
That makes sense. But, what about in terms of other cardiovascular conditions? If a family member has had AFib or congestive heart failure, something that is not necessarily a dissection or aneurysm. Is there any relationship to those cardiovascular conditions and SCAD? And if so, should those patients also be pursuing genetics?
I'll answer that. I mean, those conditions are so common just in the general population that, and we don't know of an association between things like AFib and heart failure, except when a SCAD causes a significant injury to the heart muscle, and that leads to an impairment in the way the heart functions. And that's the way you could connect the dots there. But generally speaking, atrial fibrillation and AFib is so common in the general population that just because we see it in a pedigree, in that family tree, it would not kind of change our assessment for whether or not a SCAD patient has a genetic form of disease.
Yeah, and the only, like we mentioned before, I mean, the only cardiovascular issues that come to mind really are the vascular, aneurysms and dissections.
The big one to be concerned about.
I suppose and myxomatous valve disease would probably should be on the list, although that is, again, just very common
Right.
outside of these conditions.
Okay. We are having so many questions come in through Facebook, and we really, really appreciate everybody's questions. We're trying to get to all of them. Anything we don't, we will try to get answers put out through our Facebook page, through our social avenues, and we will have future webinars too. So thank you for all these great questions. One, Dr. Hinken, I wanted to ask, you mentioned that there is a gene that might be related to FMD and SCAD and cervical artery dissection. Is that, do we know the name of that gene? Is that public knowledge or?
Yeah, let me, I was looking more about it. I'm not a geneticist, so I was just educating myself more on that. If Dr. Lindsay, you remember it quickly, I have it on my computer here. It's the factor 1 gene, PHACTR1 gene, and it's been looked at for both FMD and SCAD. And I believe there is a lot of exciting research happening at Mount Sinai, actually, with Dr. Olin with FMD as well. Again, this is all research-based work right now. This is not available. Most physicians will not know about this unless you are specific in the world of genetics. Even I had to remind and educate myself a little bit more about this as I was preparing for this. So again, something that may be on the horizon, research-based, not widely available.
Yeah,
Absolutely.
If I could weigh in on that, I think it is exciting from a research standpoint, but I think right now it's not something that we would use clinically to help anyone understand their FMD. So I want to make sure people don't. It's a test that'll. Or it's not a test. It's a finding that'll help us understand how the arteries work, and hopefully someday be able to develop therapies based on that, but not something that you should feel like, if I don't get that testing, I don't know, what's going on. That's it's really research right now, and something I don't think is going to be useful clinically for some time.
Absolutely. I'm glad you both discussed that in more detail, because I gave the preface at the beginning that a lot of the things here are in research or in flux, but not necessarily something we can take to each of our providers to go test for this specific gene yet. So really interesting to hear about what's on the horizon. With that, kind of brings up, sometimes we get questions of variants of unknown significance. When somebody has gotten genetic blood testing, should those be followed up, or what sort of follow-up should happen for those patients? Given that families grow and change, given that these are, a lot of this is still in discovery, should patients have follow-up genetic appointments? What should happen next if you haven't found the specific thing to follow? Everybody's smiling.
I can just give a little background on what a variant of unknown significance is for the audience that may not be familiar. So everyone has basically the same genes, but the genes are supposed to be kind of spelled out in a certain way. We think about the genes as being spelled using a chemical alphabet, and the order of the letters in that gene spelling is supposed to be in a certain order. And if the order is changed, or there's a misspelling or a typo that is significant enough to cause a problem, that's when we use the term mutation, and when we consider that the type of gene change that can cause a disease. But a lot of times, when we do genetic testing, we find changes in the gene spelling that haven't been discovered before, or maybe they've been seen in a handful of people and they haven't been definitively associated with a disease. We all actually have changes in all of our genes. So 99% of our genes have some change that may or may not be significant. And most of those are probably benign. Most of them are not capable of causing disease. So most variants of uncertain significance over time get down classified, but not all. And a variant that's classified as uncertain significance just means there's not enough evidence to make a call, and it can't be used for any real decision making. It can't be used to make a diagnosis, and it can't be used to screen family members. So for that reason, I do recommend that patients who have had genetic testing and have that type of result keep track of it in some way. It's difficult because the doctor who orders the test may not be notified if the result changes over time. Sometimes the laboratory that performed the test will decide that they have enough evidence to change the classification one way or the other, but that information doesn't always get to the doctor. So the patients who've had genetic testing, they should really take ownership of that data and follow up with the ordering doctor, maybe every 2 or 3 years. That's about as long as I would, the landscape doesn't change more rapidly than that.
Excellent, thank you. Did anybody else want to add anything? I wanted to give everybody a chance if there was anything else you wanted to add or feel like you haven't had a chance to. No, so I'm going to use that. What's that?
I was just saying that was perfect. Thank you.
Oh, okay, I'm going to go ahead and wrap up then, and this will conclude our third Ask the Experts, a conversation hosted by SCAD Alliance. I really want to thank all 3 of you for discussing all this with us and taking the time this afternoon, and thank you to everybody watching and participating on both Zoom and Facebook, and anybody watching the recording afterwards. This has been really informative and empowering. A link to the recording will be posted on our social media pages and also emailed to our listserv. So if you're not already on our listserv, you can subscribe at scadalliance.org and follow us on social media. Our next webinar will be in September, and you can look forward to that. Thank you all so much.